Starting.
Yeah.
All right, guys. Good evening, everyone. Give me a great pleasure to start the first journal club.
Recording in progress.
Good evening, everyone. Give me a great pleasure to start the journal club, first journal club for PAVSS for 2024. We have a great panelist with us. We have Dr. Munir Nazzal from USA. We have Dr. Luay Abbani from also USA, from Henry Ford. Dr. Jamal Hubballah from Lebanon, from American University of Beirut. And we have Dr. Mus'ad Sulaiman from Mansoura in Egypt. We're going to discuss two papers. The first paper will be presented by our fellow, he's the third year, Dr. Ahmed Al-Mumtin. He's the third year fellow at King Faisal Specialty Hospital in Riyadh. And the second paper will be presented by Dr. Islam from Cairo. So we'll start with the first paper by Dr. Mumtin. Please go ahead, please.
Okay.
Your slide. Yeah.
Good evening, everybody. I'd like to have this opportunity to thank all the panelists, my moderator, Prof Samer Koussayer, and all the attendees and the Pan-Arab Vascular Surgical Society for this opportunity to present this wonderful paper. So starting with a paper that talks about the direct oral anticoagulants over warfarin at discharge associated with improved survival and patency in infrageniculate bypasses with a prosthetic conduit. This paper was published in the Vascular and Endovascular Surgery Society in February 2023, last year. And authors have been also known to be from the Division of Vascular Surgery, Endovascular Surgery of Harrington Heart and Vascular Institute, University Hospitals, Cleveland Medical Center, and Case Western Reserve University, also from Cleveland. And this journal is known to bear an impact factor of around 4.4 as of last year. As an introduction, this has been studying the patency of lower extremity bypasses performed for peripheral vascular disease, and the patency rates that have been reported around 40 to 88% in the first year. Antiplatelet therapy has been the standard of care and has been widely accepted and well shown to be beneficial. Anticoagulants, however, were not as much studied. However, in recent trials, multiple trials, including the different anticoagulants, especially after compromised veins, the prosthetic bypasses, with those with poor outflow or run-off vessels and those in hypercoagulable states. And warfarin, the cheap and available, has been also the gold standard anticoagulation. And over the years, recently, DOACs have emerged. Different medications are available in the market as an alternative modality that, theoretically speaking, offer few advantages, including a shorter hospital stay and unnecessary monitoring, which makes them really bear better patient compliance and potentially less bleeding risks. Several studies also came in to support these medications in atrial fibrillation and venous thromboembolism, also in an outpatient settings. Other databases, including the Voyager, have shown better outcomes with Xarelto as a combined therapy with aspirin in comparison with aspirin monotherapy. Other papers, conduit type, also affected the outcomes in comparison with warfarin to DOACs. And the recently published in the New England Journal of Medicine, the famous and wonderful BEST CLI have also came in comparison with single segments greater venous vein in comparison with endovascular therapy and have shown superiority. So whether or not using anticoagulation after vein bypasses a rule is unclear, and whether DOACs can be a really good alternative to warfarin and would add few benefits on patency, overall survival, or males, or major adverse limb events. The aim of the study, when studied, is actually to compare the following outcomes for patients managed with warfarin versus DUOX after infrageniculate vein or prosthetic bypasses. They came to study the overall survival, the primary patency, amputation-free survival, and if males. So the design was a retrospective cohort analysis of VQI and infrainguinal bypass module, included patients between 2003 and 2020, and studied groups were either prosthetic or vein, and either group whether randomized whether received warfarin versus DUOX. Inclusion criteria were Rutherford 3, 4, or 5, 6, or tissue loss, simply tissue loss, claudication, wrist pain, who underwent below knee, popliteal, distal targets, tibial, or distal targets, whether receiving warfarin versus DUOX. Dosage and certain medication of the DUOX have not been really available to compare as well. The exclusion criteria: any patient who was not anticoagulation naive, and those with concurrent endovascular therapy, those presenting with acute symptoms and bilateral procedures. The outcomes studied the overall survival that includes any mortality from any cause, primary patency, whether from the time of bypass until either restenosis or repeat intervention in the same arterial segment, major amputation or amputation-free survival include amputation above ankle on the treated limb or death from any cause. If males have been studied as a composite endpoint, including untreated loss of patency, repeat intervention on the same arterial segment, or any amputation above the ankle of the treated limb, or death from any cause as a composite variable. So what they did is they collected data of about 50 or 58,000 patients, excluded initially the 400 patients just because of the initial screening, and then furthermore about 20,000 patients were also excluded, having a bypass origin from the iliacs, popliteal artery, and also the further excluded 10 more thousand patients who had anticoagulations preoperatively, and then further the big jump in about 10,000 patients were also excluded afterwards, having a concurrent endovascular therapy or discharged on antiplatelets alone, wrapping up about in 3,200 patients. Those were studied whether receiving warfarin or DUOX, whether following prosthetic or vein bypasses. If you look carefully to this diagram, it shows you something that's very interesting here. Over the last few years, from 2014 to 2020, range of increase in utilization of DUOX from 14% to around 77% in the years in 2020. If you look at the demographics, I apologize. If you look at the demographics, after studying those patients, we ended up with 3,200 patients who were anticoagulation naive with FIMPOP, whether using vein bypasses, which was utilized in about 51% of cases in comparison with prosthetic received in very close number in 41% of cases. If you look carefully at the on the demographics, whether patients receiving DUOX or receiving warfarin, is among the study group, has been significantly differences observed in those patients who received Medicare kind of insurance, those discharged home, and those on dialysis. So if within the vein conduit cohort, those who received DUOX were more likely to be Black, African American, those with a private insurance living in nurses' homes, those who were vascularized into distal targets, including the TBT, as well as posterior tibial targets. The indications of bypass, preoperative aspirin use, preoperative antiplatelets, and the ankle breaker indices were similar in between both groups, whether vein or prosthetics. However, within the prosthetic conduit cohort, it has been observed that those prescribed warfarin were more likely to be associated with also Medicaid insurance and had a prior history of ipsilateral bypasses and associated urgent presentation. In these two tables comparing prosthetic over the right-hand side and vein conduit on the left-hand side, poor bypasses affected the outcomes, whether in warfarin or DOACs have been observed, so is bypasses to below knee popliteal vessels. In the prosthetic, preoperative depth has been also observed to be significantly affecting outcomes, the poor bypasses and being elective procedures. Now, looking at the univariate as well as monovariate, the multivariate analysis and univariate analysis, looking into the overall survival, all domains of primary outcomes, the vein conduit, primary patency, the survival as well as amputation-free survival, and if males have been all observed to be insignificant in patients receiving anticoagulants. The picture is a bit different when we come to the bypasses using the prosthetics. So multivariate analysis also studied the patency rates, mortality, as well as the amputation risk, and if males. Age have been corresponding really positively in it, actually negatively in patency as well as mortality, so is presenting with wrist pain or tissue loss. In terms of amputation as well as if males, wrist being a wrist pain patient as well as tissue loss being on dialysis were also significant measures. Looking at the multivariate analysis, taking in consideration prosthetic conduit, it's been observed to be significant, to make significant difference in patients receiving anticoagulation with significant values in all domains, in the overall survival, primary patency, amputation-free survival, and if males. So patients discharged on DOACs were associated with improved outcomes out to 1 year in terms of overall survival. If males and as well as the amputation-free survival. In conclusion, they ended up wrapping the whole story that patients with for patients being initiated on anticoagulation following infrageniculate bypasses with the prosthetic material, the use of DOACs was associated with improved free survival, improved patency, amputation-free survival, and freedom from major adverse limb events when compared to warfarin. However, there was no clear difference in outcomes seen for patients with vein bypasses. Looking at the inside of the paper, the study incorporated all below-knee targets, including tibial and crural. The more well-studied patency rates were in proximal targets. The current rates of femoral to above-knee bypasses with prosthetic conduit have been better, 60 to 80%, and femoral to below knee have been seen to be around roughly 40% at 3 years in comparison. Limitation of the study have been also seen overt to be retrospective in nature, which could render any study riddled with selection bias. The significance of reported significant loss of follow-up after the index hospitalization was in 58% of cases. Their data did not include any exact medication of DOACs that has been used, neither the dosage. The reason patient discharge and anticoagulation was not also recorded in the VQI. And looking at the question that we normally would answer in this thing, I tried to use something in modern life, AI, and AI was perfectly able to answer the questions in all regards of the paper, including the introduction, in which it sets the context of the study, discussing the challenges and determining the optimal anticoagulant regimen following the bypasses. it was effectively highlighting the gap knowledge regarding the efficacy of DOACs in comparison with warfarin. The methodology has been also adequately described the study design, data sources, and inclusion criteria. The use of VQI in infrainguinal and infrageniculate bypass is appropriate for this type of analysis. The statistical analysis are clearly outlined, including the survival analysis, multivariate Cox proportional, and hazard analysis. The results were also observed to be really presenting the key findings in the study include structured manner. It included important details such as the number of patients treated, including the analysis, the distribution among both the groups, whether prosthetics or vein bypasses, the use of either anticoagulants. The discussion also incorporated findings listing the literature and clinical implications, as well as acknowledged the limitation within the study. The conclusion succinctly summarized the main finding of the study, underscored the importance considering the type of bypass conduit when choosing the discharge anticoagulation. It reiterates the superiority of DOACs over warfarin in patients with prosthetic conduit. Conclusion was effectively communicated through implications of the study, clinical decision making, and it really would affect my own practice in the future. And I will leave the floor really open to answer these questions. So do you, the panelists as well as attendee, believe that this research did really answer the question that was asked at the beginning of the study? I believe I would choose yes. And the authors in which I already mentioned who at which institutes and the level of expertise they have, well, I would say yes. So the study design, did it allow for answering the stated objective? In the end, yes, we knew that the DOACs did the benefit that is intended to do in the prosthetics, and the population study number of patients included, record reviewed, inclusion exclusion criteria were really appropriate, and the concerns, although we did not look so deep into the statistical analysis, what appears from the summary of the data published in the paper were really no concerns I've seen with it. So is the sample size. So are they really comparable? I believe yes, looking at the standardization and in the way they collected the data, and it really addressed the stated design. So I do myself agree with the conclusions. I don't know if you guys who are much more experienced in the field of vascular surgery agree with their conclusion, and it definitely would affect my practice. I came to the conclusion, ladies and gentlemen. Thank you very much for listening and giving me this opportunity.
Thank you, Ahmed. Very good job. Really very nice summary of the paper. You did a great job. You just went to the point. We didn't waste too much time talking about something not related to the paper. And the conclusion was very obvious, you know. I like the way you put that question. You answered them very clearly. I think it's a good paper. Of course, I will leave it up to the panelists and the audience to decide that. I think it's a good paper. But I have a question for you. First, two questions. First question, why you think that the anticoagulant work with the prosthetic did not work with the vein? The first question. And the second, why in the prosthetic, the DOAC was better than warfarin, in your opinion? Why is that?
Theoretically speaking, since we're talking about bypasses, and especially we're talking about veins and the thrombosis in veins, we know that anticoagulants has been like the drugs of choice in any venous disease. However, this study did really come to surprise that it did not affect any outcome in those vein subjects. To be honest, it was surprising to me to look into these outcomes. So I really have difficulty to interpret why would it really affect. But we know that prosthetics are only used mostly to save as a last resort and saving just to heal an ulcer for very temporary short period of time rather than to use it as a long term to prevent the decrease in patency rates.
Okay. I mean, I don't know really the answer, but I have a theory. I think the reason why the vein thromboses all the time is because of the progression of the distal disease, where the reason why anticoagulant will not make a difference. With the graft, when they thrombose, mostly because of thrombogenic materials. The reason why anticoagulant will work, and the prosthetic will not work in the vein because it's different reason why they thrombose. You see, vein thrombose because of the progression of the disease, where the graft mostly because of the thrombogenic graft material, why warfarin is better than DOAC? I think because DOAC, you have more like maintenance of the dose. You see, with the warfarin, you can see from our experience, patients, sometimes the INR is too high, too low, so you have fluctuation. So where with DOAC, you can have a stable dose. I think maybe the reason why we see it better DOAC with a prosthetic than warfarin. It's just my opinion, but I'll leave it up to the panelists to give their opinion. Jamal.
Yeah, once again, very nicely presented, Dr. Ahmed. Nicely done. I agree with the comments made by Dr. Koussayer that about the potential reasons why the DOACs work better than the warfarin as far as the patient being more compliant with the utilization of the drugs. We have always known that the vein bypasses, unless the patient has a ongoing hypercoagulable state congenitally, like factor V or MTHFR, that anticoagulation with warfarin was never shown to have a significant effect in the single conduit veins. So that's why it did not show any replication between DOACs or warfarin in this study. So I think these are the comments that I have. I think one of the limitations also is we don't know which patients were on, in addition to the anticoagulation, were on antiplatelet therapy. And it was not clear to me whether all the patients were on one or single or dual antiplatelet therapy. So I think the question remains to the group and to the other panelists and experts on this panel is how is this going to change your practice now? Are you going to put your patients on DOACs on a prophylactic dose, or are you going to put them on a therapeutic dose, and are you going to add to it an antiplatelet therapy or not? Yeah. I can tell you my inclination would be to probably, I would not say my inclination, but let me stop at this stage and not influence anyone. I would let everyone else comment.
And you want to answer that, or give me your retrospective analysis of the paper?
Yeah, I have one question for Ahmed, and it puzzles me that when you look at mortality and overall survival, there was a increase in survival with the DOAC as opposed to antiplatelet for the grafts, right? Okay, why do you think that is? And I'll ask you first, and I'll give you my interpretation of it.
I was actually, when they looked at the study did not compare antiplatelets versus the DOACs, and they were comparing with warfarin versus DOACs, and probably in response to what Dr. Samer mentioned earlier, that those patients on warfarin were particularly not always within the target treatment INR. And this could explain this difference, because many of those patients are not only receiving warfarin for the bypasses themselves, and many people will recline, although yes, they included in their criteria of inclusion, they did not include any patient who were already receiving the anticoagulation, yet after the procedure, we don't know exactly the condition of those patients who received the other anticoagulation for any other reason other than the bypasses. It is not really clear for me why exactly DOACs did achieve this difference aside from this.
Yeah, so you're at a disadvantage because the VQI is a American registry, and you have to understand why we prescribe warfarin for some patients and we prescribe DOACs for other patients. And there are a lot of patients who can't afford DOACs. And DOACs in the US, if you don't have a good insurance, you're paying $450 a month for DOAC therapy. So when we prescribe patients for anticoagulation, we all agree it's easier to prescribe DOACs, but if the insurance is not going to cover it, then we step back and prescribe warfarin, which is very cheap, which is $2 or $3 a month. So in my opinion, one of the co-founding variables that they did not measure and that may be affecting their decision is that the patients who were prescribed warfarin were probably of lower socioeconomic status. And if you think of it that way, we know lower socioeconomic status, poor patients always have less survival, less compliance with the medication, less patency of the drugs. So they may be, and I'm not 100% sure, but they may be looking at socioeconomic variables, but they can't measure it, right? Because the socioeconomic variables is a co-founder, and prescribing warfarin is a substitute to lower socioeconomic status.
Yeah.
Does that make sense?
Yeah, it makes.
So that's my take about it. I think that the study shows that there's probably no difference between one or the other. I'm not 100% sure that DOACs actually is better because I think there's some co-founders that they couldn't measure.
Yeah, I totally agree with Luai's opinion. I think the people taking warfarin are usually social class 5. And there was one sentence in the States that your zip code, where do you live in USA, has more prognostic factors than any other test that you do. So I totally agree with your opinion.
But this is regarding survival, not the patency, because it showed the patency even is better with a DOAC than with a warfarin. And I think it's something to do because, as I said, fluctuation of dose of the warfarin and the compliance with warfarin versus DOAC. But I agree with you regarding survival, yes.
Yeah.
I saw your hand up. You have anything to add, Masad?
Yes, I will start with the question for the panelists. How many of us are using the wax or any kind of anticoagulation in a straightforward patient with autogenous bypass? How many of us are using any kind of anticoagulation?
I don't do. I don't use
Is it for graft patency or for graft patency?
I mean, for the patency.
Yeah.
How many of us are using any kind of anticoagulation for forward good quality vein and with autogenous bypass for femorodistal bypass, infragenicular, supragenicular? Because this is the point, because in my whole practice over around 40 years, I've never used anticoagulation for a straightforward autogenous vein bypass. And this is not an optional thing because I didn't find it something that we need. Exactly, it is the same for doing a straightforward arteriovenous fistula for a patient with dialysis. How many of us are using any kind of anticoagulation? We give nothing for these patients. So I'm wondering why the author is surprised because he found a kind of difference between using the DOACs and the autogenous, and he didn't find any kind of difference on the autogenous side, but he found on the sensitive side, because the autogenous vein doesn't need anticoagulation at all. And you will find any kind of difference, you are searching something that is not there, because a good quality vein, especially in a reversed way, with a good anastomosis, a good target vessel, inflow and outflow, you didn't need any kind of anticoagulation. This is a main point I have to raise, and this is a point I take over against the quality of the study. The other thing is lacking for an enormous data like the dosing and the type of the DOAC, which to myself, it matters a lot, because using apixaban is totally different from using rivaroxaban. And the studies he referred to, like the Voyager and the Compass study as well, they used the rivaroxaban. But on the other hand, we found so many privileges of apixaban now, but he didn't refer to the type of the DOAC used and the dosing as well. I wonder much more, he didn't put the hemorrhage or bleeding risk as a secondary outcome, because this is the most important thing you got to do if you are using any kind of anticoagulation. What are the bleeding risks for all these cohort of patients? I didn't know. He has around 79 patients on dialysis, and he didn't mention what kind of drug did you use for these patients with chronic renal failure or a chronic kidney disease on dialysis. And what is the bleeding risk for these patients? Because this is a very high limitation to use a drug like the rivaroxaban in patients with chronic renal failure, as we all know. So I found that he didn't answer much of the primary outcome, and he didn't define what is the secondary outcome, and he didn't follow that to achieve in the scope of the results, that he didn't achieve the outcome. He just said, I didn't find any improvement with the drugs on the autogenous, which I know by heart that it wouldn't change anything in the game because they are needed at all. I can say it clearly, they are not needed. We have in our center a recent study comparing the double antiplatelets with the wax combined with aspirin in patients following any kind of endovascular intervention. And it is pending in the European Journal of Vascular Endovascular. And what we reached, we didn't find any difference between the two types of combinations, whether the WAC with aspirin or the double antiplatelet. We didn't find any kind of outcome in the primary or the secondary outcome. They were the same. So I mean, I have some comments against. On the other hand, it's a really big study, but the retrospective aspect makes it, it needs some more act to be done. Thank you.
Thank you, Masad. Really, thank you for your comments. I agree with everything you said. I just want to do some correction that about the vein bypass. When they put an anticoagulant, this was for compromised vein bypass, like small vein, problem with the vein. I don't think they put a patient anticoagulant for straight good vein.
Yeah.
The reason why not every patient with a vein bypass was anticoagulant. Regarding those and typing, I agree 100% is very important. And this was the one of limitation of this study. I agree with that. Munir, I see your hand up, Munir.
Yeah, thank you. Well, looking at limitation, it's administrative data. We agree on that. But looking at the study as a study, it's a good study comparing two groups, relatively large sample size. One of them double the number than the other. But the problem with anticoagulation, whether we use it or not, it's preference based on a lot of things, not on like somebody have heart failure, for example, you end up using it because there's stagnation. But warfarin in general, more difficult to manage. Number one. Number two, there's nothing in the literature, in this paper, I mean, mentioned about how frequent the anticoagulation was stopped. Because if you stop in Coumadin, that's almost 7-8 days. If you stop in DOACs, 1 or 2 days. These are important factors. But this study is consistent with other studies that DOACs at least comparable to warfarin, but knowing it's more difficult to manage, it makes it better than warfarin on those patients in general. About the zip code, it depends on the insurance, and most people in the zip code is Medicaid, the poorer area, Medicaid or Medicare. In this paper, Medicare group was about 15%. So it's not very high Medicare group here. The last comment I have, it did not mention anything about the outflow. So this is what you get from administrative data. The outflow on those two groups, are they different or equal? We don't know. Nothing mentioned about the characteristics of the arteries, calcification, difficulties. This is what makes the difference, and not really blood thinning or no blood thinning. This is what's missing in this study. But generally, it gives the idea, if the patient is straightforward and you do a bypass, better to do DOACs because of many reasons than to give Coumadin in prosthetic grafts. That's the study says, which I agree with.
Jamal, your hand is up, Jamal, please.
Yeah. I just want to comment again on what Dr. Musab just mentioned earlier. So we all agree from our experience that vein bypass is a good vein. There is no need for any anticoagulation except if the patient is a hypercoagulable patient. But you need to have antiplatelet therapy for those vein bypasses. So I think what this study did is confirming some of our existing beliefs that in vein bypasses, there is no real need for anticoagulation, whether warfarin or DOACs. Now, as far as prosthetic bypasses, these are where you can have so many factors and can affect the patency, and that's where the anticoagulation can play a role. And as we all commented, that the DOACs are going to be easier to control, easier to manage if the patient can afford them. But if the patient has renal failure, for example, you may find you are better off with warfarin because you can control the dose and monitor it better, and you can deal with it. But there are so many variables. You have to really ultimately decide and individualize your patients. I think we go back to what would be our recommendation, and I would like to know the recommendation of the panelists of the panel. What would you give now based on what your experience and what you learned from this study on your patients who undergo a PTFE bypass for some reason or another below the knee? Are you going to give warfarin? What dose? Are you going to give DOAC? What dose? And are you going to combine it with an antiplatelet therapy? Will you use like the rivaroxaban data 2.5 milligram BID with aspirin, or would you give a therapeutic dose with aspirin? So that's my question to the group.
Okay, who's going to start? You want to start, Musab?
Yes, for me, I am not going to change any of my ideas. For the synthetic, I refer to the double antiplatelets, but for the straightforward, the vein uncomplicated, I use only aspirin if it is a matter of choose. For all cases of endovascular, I use a double antiplatelets or DOACs.
Munir?
So actually, for prosthetic below the knee, I give Xarelto or Eliquis plus aspirin. And I start full dose for 2-3 months, then I go the small dose. For veins, I go double antiplatelet therapy.
Go ahead.
Yeah, so like everybody else for vein, I just do single antiplatelet, don't do double antiplatelet. And then for below knee prosthetics, I use aspirin and a DOAC. If they can't afford the DOAC, then it's warfarin.
What dose? At what dose do you?
I use full anticoagulation dose.
Full
I don't use the dose. Yeah, I have a lot of problems with the Voyager and the Compass trials. A lot of issues with those.
Omar?
Yes, I use the same regimen as I probably I just don't add antiplatelets. I have a lot of complication with bleeding when I add antiplatelet to DOACs in synthetic. We usually say vein is the best, plastic is better than nothing. I'm very rarely use plastic below the knee, but if I did, I use DOAC without antiplatelets to minimize the bleeding. Still, they are not as good as veins.
Great. So it looks like there's consensus here about the treatment, and this is very good. So I think we can wrap it up now, and we can start with the second paper. Dr. Omar Farouk is going to take over.
Okay.
Please, Dr. Omar.
Thank you very much, Samer. I would like to present Dr. Islam. He is a university staff member here in Egypt, and he is also working in Ireland, in Galloway, with a very big center with Gary O'Sullivan. He is, I was told, he is the right hand of Gary O'Sullivan at the moment doing the research, and he's going to present the paper, which was very enjoyable for all of us to read. Dr. Islam, you can start.
Thank you, Dr. Muhammad. It is great chance for me to be here with my dear professors and my colleague in PAVSS Society. Our paper today is about predicting wound complications following lower extremity revascularization. It is online published in Journal of Vascular Surgery, one of Q1 journals or with high impact factor 4.86. It is recent paper published 3 months ago in November 2023. As we know, in the management of chronic limb-threatening ischemia, we will use open revascularization or endovascular treatment or combination of two approaches. And also, surgical site infections are one of the most common complications after revascularization, especially groin infections are reported from 8% to 31%. There are several prognostic factors that studied as a predictor of postoperative complication, such as sarcopenia and frailty. And there is also independent risk factor for surgical site infection, such as obesity, diabetes, and functional status, and smoking and female gender. What about clinical frailty scale? It is a tool used to assess an individual overall level of fitness. It will contain 3 domains: comorbidity and function and cognition. It will take a score from 1 to 9. 1 score is very fit, and the 9 score is terminally ill. Our aim of this paper was to create a simple risk score to identify factors associated with wound complications after infrainguinal revascularization. This paper is a retrospective study done in national 3 multi-centers in USA, in Brigham and Women's Hospital, Boston Medical Center, and Harvard Medical School from 2005 to 2021. It will done in large sample size, about more than 22,000 patients undergoing elective open revascularization for peripheral arterial disease in stage 2 and 3 and 4, and also in peripheral aneurysms disease. But in exclusion criteria, emergency and trauma cases were excluded. Was wound complications such as wound dehiscence, superficial and deep wound surgical site infection within 30 days of the operation, and secondary outcomes including myocardial infarction, bleeding, sepsis, and length of hospital stay. There is 8 independent risk factors for wound complication from the model risk model score. Number 1, age less than 73, body mass index more than 35, non-Hispanic whites, diabetics, TLC count more than 99, and absence of coronary artery disease, operative time more than 6 hours, and undergoing femoral endarterectomy with bypass. Age, diabetes, TLC, absence of coronary arterial disease, operation length more than 6 hours, each one will take score 1. Non-Hispanic white, endarterectomy with bypass will take score 2. And the body mass index more than 35 will take, the largest score is 4. So the summary risk scores will be from 0 to 12. If it from 0 to 3, it will be low risk. If from 4 to 7, it will be moderate risk. From 8 to 11 will be high risk. And if we more than 12, it will be very high risk. So it will be considered in the body mass index more than 35 is the largest score by 4. So statistical analysis was conducted by R version. It is one of programming language for statistical computing and data visualization. And there is a baseline characteristic of patient with wound complication according to the age, according to the TLC count, comorbidities, and prior stroke and procedure type. Also the predictors of wound complications, the 8 parameters: body mass index, non-Hispanic whites, endarterectomy with bypass, absence of coronary artery disease, and the age, diabetes, and operation length more than 6 hours, and TLC count. And there is each risk class from low and moderate and high and very high risk classes. The conclusion of the paper is the wound complication rate following infrainguinal revascularization remain high, regardless of surgical indications. Also, the patient with high body mass index are undergo high risk combined with femoral reconstruction in conjunction with bypass. This score will serve as a decision and discussion and aid preoperative expectation regarding post-operative complications. The first prognostic model used for this score is Pain Groin Assessment Scale. This score will take score from 0 to 7. It will be done in 2012 in single center in USA also. It will be used small sample size, about 68 prophylactic flaps in 53 patients, and about 195 open femoral access without flaps. It will be to score from 0 to 7. If the patient is obese, it will take score 1. Smoking 2, reoperation also 2, and synthetic graft 2. In this model, we will give a chance or give a goal of constructing algorithm to guide creation of prophylactic muscle flaps in the index vascular procedure or not. There is many positive point in our paper that is large sample size. It is published in one of Q1 journals, such as Journal of Vascular Surgery, and recent study. And there is incorporation of wound class defined by clean or clean contaminated or dirty infected wounds. Obesity and diabetes. Diabetics are strong indicators of wound infections, and this is pointing system in risk score. But there is many negative points. Retrograde missed data. It will be concentrated in white races only, and not involve the practice of prophylactic muscle flaps, and also not involve smoking is one of the predictors, risk factors of peripheral arterial diseases, and long surgeries more than 6 hours not included, and also not categorize the level of the lesion. So our recommendation for the paper is international multi-center studies, and the more races, black races, it will be involved, and involvement of prophylactic muscle flaps, and the more studies in wound complication rate and different surgical indications, standardization of techniques, and dividing the lesion level for revalorization, and including more risk factors such as the smoking history. And thank you.
Thank you very much, Dr. Islam. Yeah. Thank you very much, Dr. Islam, for such a great presentation. I would like to thank you very much. He took much time, more or less around 2 weeks, to read the document thoroughly, which touches a lot of the clinical practice. I will just ask you a couple of questions. I would like first to thank Professor Jamal Hubballah. He have provided us with a scheme of questioning for the journal, which I think we should all follow in our journal club. My question to Dr. Islam, did this paper affected your clinical practice after you have read it?
Sure. We didn't have any risk score to identify factors related to wound complication after infrainguinal vascularization. The last one is pain scale. It is single center and not include many prognostic factors. This model will including many factors, such as 8 risk factors that I say, and the high risk scores will help us to exclude post-operative complications following lower extremity revascularizations.
Okay. If you can stop sharing your screen, so we'll go back to the screen again. Okay. The second question, Dr. Islam, the presence of wound infection with the parameter of high-risk patients that you have mentioned, there was no mentioning of female patients. Why do you think this has happened?
Yes, it's one of drawbacks in this paper, that more complication and obesity more than in females, and it is a high score in this scale. So I think our recommendation, we will aid male gender in the next papers to be more broad scores.
Okay, I can see Professor Munir Nazar have a question. Please, Professor Munir.
So thank you. Dr. Sam, if you can stop sharing so we go to the full screen.
Sorry, is it me? I'm not sharing mine.
Not no, it's Islam, the presenter, not you.
Islam, if you can, on the red button, stop sharing, if you can press on it. That's it.
Okay,
That's it. Okay.
So this is actually a nice statistical paper. That's all. It's nothing good about it from the point of view clinical for many reasons. The first one, I call it the statistical exercise paper, adjusting the clinical factors into statistics, which we do a lot of it here at UT. The first thing, the tissue loss in the ICD is difficult sometimes to define it. So they remove the tissue loss. The other thing, they dichotomize the results, which is bad. In clinically, you should not dichotomize the result. You need to know which result you are using. For example, they dichotomize the renal failure into only 1.5. What about those who have dialysis or higher than renal failure? This can change the analysis. The other thing, there's a lot of missing data, but instead of excluding them, they use the median. And that can also change a lot. It depends how much data you are using. If you have, for example, 30% of certain factor missing data, you should scrubbing the data include removing that data. You should not add the median, especially if it affects the analysis. The other thing, the age, they again dichotomize the age for the ease of analysis, 73 or more or less. This is dichotomization. You should go to different stages, but that will make the analysis very difficult if they go to different times.
Yeah.
The last thing, not the last thing actually, there's a lot, but I will stop at certain ones. They used, it's a large data, but they divided it into 2/3 derivative and 1/3 validation. And they said that is what the literature is recommending, yes. But for large data, it's better to go 90-10 actually, or 80-20.
Yeah.
They went to 67% and 33%. So you need to make sure your model is very accurate when you do artificial intelligence modeling. They use the R, which is a very good model, R better than many others. But the dichotomization was the issue. The other thing, they use the area under the curve to examine the goodness of fit, which is good, but they did not say how much it is.
Yeah.
Like in some of the studies, is it 80%, is it 90%, is 60%? It should be minimum 70% to accept it. I don't know what was mentioned in this paper. I read this paper also. They used the mean to define factors. So what did they do? They studied and they used the mean, they compared, and they used the Penn scale, which was based on mean, which is a problem.
Yeah.
You should go to odd ratios.
Yeah.
You should give the factors the odd ratios and don't depend on another scale that was based on 68 cases only. You need to create your own scale if you are writing artificial intelligence, and take the highest number. If you want 10 factors, the highest 10 with the highest odd ratios or whatever you use for that, and analyze those.
Yeah.
Don't go to somebody else analyzing the past, which might not be accurate on 68.
Yeah.
So it's a very good statistical paper. If somebody wants to learn how to do AI paper, it's not a good clinical paper because they excluded a lot of factors that are clinically important.
Yeah, I
That's my
totally
opinion.
agree with your point, Munir. Actually, they have 22,000 records, and this is from the initiative of quality of recording in United States. They collected the data, and they said, because we have so much data, we're going to do the study on 2/3, and once we got the equation, we'll apply it for testing to know how accurate it is and what is the confidence about it in the last third. But I totally agree with the statistical falls that they fallen into, which is definitely will enlighten any future plan. Now I have two questions from Professor Jamal Habballah first and Professor Samer. Professor Jamal.
I think Samer raised his hand before me, so
Oh,
I would
sorry.
like
Okay.
to
Okay, Samer.
I want to اتفضل.
عشان الرئيس دايما رئيس عندنا بيه
لا
حتى
لا
رفع
لا
ايده متاخر.
democratic
ميدل
thing,
ايست
so
بقى معلش ما بابس يلا سامر اتفضل.
I think that it's a very nice paper, but as Munir said, I don't see any clinical applications. I mean, they should tell us this information we got it. How going to you applying our practice. The only thing they said, you have to tell the patient about the risk. But then tell us any recommendation. Should change the antibiotic? How long should be an antibiotic if you have high risk? Should we use a muscle flap if patient high risk to decrease that? You see, this is the most important for me when I write a paper to get some clinical application for this paper. But what they said, they just use this information just to tell the patient what's the risk of infection. But they didn't say anything about how we can use this data to decrease chance of infection.
They just give a hint that you can use prophylactic muscle flap. If you think that his score is high, more than 12, then there is an indication to prepare yourself for sartorius flap for that groin and do prophylactic. So you do marking for the rotational flap pre-operative. And this is what Benny has done in his Benny score. This is the only clinical difference. I totally agree with you. Secondly, they notice that the people who have cardiac disease, they get a lot of wound infection. So they think if you prepare the heart better with adding a statin, you get less wound infection afterward. But I totally agree with you. If it's just the benefit that to tell the patient you have high chance of infection, it didn't add anything. But this is the two things I think that I take out of it. But I totally agree with you, Samer. Jamal?
Yeah, thank you. I totally agree with the comments made by Dr. Munir or Dr. Samer. I think that if we are going to criticize the paper from statistics and from the design, etc., it's an administrative data that is flawed with all the challenges that you meet with administrative data, and the comments made were very clear. But if we want to try to make something out of this paper that we benefit from, it helped us identify some of the risk factors that are associated with a higher rate of wound problem. And one of them, they said the common femoral endarterectomy, because that involves a longer incision, etc., or at least longer arteriotomy and other factors. But I think at the same time, the identifying a obesity or other factors is important in planning your operation to avoid the complications or the morbidity of the wound infection. And they didn't mention anything about the technical aspect. Were these wounds that were in situ bypasses? Were these tunneled anatomically, subcutaneously? Because once you identify a patient that is at a high risk of having a wound complication. One other thing about wound complication is steroids. We have a paper coming up identifying or demonstrating the importance of steroid in use in increasing wound complications. So once you identify that you have this group of patients that it's a high risk, then you have to modify your techniques a little bit. One of them may be coming off the superficial femoral artery rather than the common femoral artery for your origin of the bypass, so that if you get any kind of infection, your bypass is already covered by the sartorius and you don't need to do a sartorius flap. You tunnel your graft anatomically or subfacially rather than tunneling your graft subcutaneously, so that if you get a wound infection, you can open that wound and don't worry about graft exposure and things like that. So I think these are my comments here, is that yes, it is it has its limitations from the statistical point of view, but you need to realize that yes, if you have a overweight patient, if you have a patient with the risk factors they have identified, endarterectomy, etc., then you need to plan and modify your surgical technique to deal with the potential complications of wound infection.
That's a great message. It's a really great message, really, Professor Jamal. I would also would like to give a hint that me and Dr. Islam, we have used artificial intelligence in analysis of this paper. There is a program which is called the Chat Doc. We did upload the paper in the Chat Doc, and we have asked the Chat GPT with this document in particular all the questions, statistical analysis, what is the knowledge gap being covered, what do you think advantages is. The artificial intelligence came with very good answer, but I agree with Samer that we should be above the artificial intelligence to measuring clinically, because sometimes can give you drastically wrong information. I can see Professor Mus'ad Suleiman unmuted. Probably he would like to add something. Professor Mus'ad?
Yes, I add my word to Dr. Jamal that and Dr. Samer as well. Any study you have in your conclusion to have some data that is telling people what you got to do in case you find this. And I didn't see this answer clearly in the paper. As you see, we have 8 factors. Above them all is BMI of the patient above 35, which is clear for everybody. When you have an obese patient, the risk of wound dehiscence is very high. But I needed a translation of this score, if there is that score, to say in such a case, do prevention other than the skin flap, because we know from all our experiences that in obese patients, we got to do every effort to avoid skin infection. And what we do in our daily practice to modify the construction of the skin incision, because we have found that a vertical incision in the groin is associated with a very high risk of dehiscence, because it is against the stria of the skin, against the Langer's lines of the skin. So there is a tension over the skin when it is constructed in a vertical way. So we managed to do it in an oblique way and then in a transverse way to avoid any dehiscence of the wound. One more thing is that we tried again to use the PICO system, which is a local aspiration system attached to the side of the patient. And I'm pretty sure you are all aware about it. And it has reduced the risk of infection by around 38%, and used it only in obese patients or cardiac patients. So my word is, lastly, when you have a score, you got to use it. Say it, for example, when you have a score of 9, you got to take all the measures, which are 1, 2, 3, to avoid any wound death.
Okay. Do you like to comment, Professor Jamal or Professor Samer?
Yeah, I would like to stress that again, when you have a patient, the point made by Dr. Musab is very important. You identify a patient who is a high risk for wound infection. You have to first use the general principles of avoiding wound infections, meaning no shaving, clipping of the skin and not shaving of the skin, pre-op antibiotics within 1 hour of the procedure, avoiding hypothermia during the operation, and monitoring, these are the general things, and the transfusion issue. Then you come to the planning of the operation. If I have a wound, you have a lot of patients that come in obese and you see that fungal infection already in the groin, you have macerated skin. These are the type of patients where you have to modify your incisions. I would avoid 100% going out from the common femoral artery. I would do my best to come off the SFA or profunda, because that will be a lower incision that is covered by the sartorius. I will find a way of, if you're going to do vein, I would harvest the vein in a way that would be maybe with some multiple incisions and leaving bridges, minimize the trauma, minimize the dissection. Be very careful about the technique, change your techniques, be very careful about how you close the wound. Very often you have your faculty, you do the operation and you leave it to the junior resident to close the wound, and they put these deep bites into the subcutaneous tissue that cause fat necrosis and ischemia to the wound, and then they close the skin in a way that is also very tight, that will cause. So you have a lot of other factors. So you identify the patient who is at a high risk to have a wound infection, and then you treat that patient gingerly, and be very careful about your skin closure. You do a femdistal bypass to the dorsalis pedis. Well, if that incision over the dorsalis pedis is not closed in a meticulous way, without too much tight, you can end up with a skin necrosis that will expose your bypass, and you end up with a bad wound. So again, I totally agree about the comment made by Dr. Musad. You plan your operation. You avoid that longitudinal groin incision if you can. make multiple incisions, and then I think these all are very
Excellent.
good.
That's a fantastic wisdom.
And I'm glad you told us about that chat dot
Yes.
program. I think we all should benefit from these things, learning so that we read a paper, analyze it, and then use the chat dot program so that
Yeah.
we compare how our analysis was with other people's analysis, and we learn from it. Well, hopefully, you can share it.
That's why
Can share it
why-
on the
Screen.
on the screen so that people can
Yeah.
use
Can use it as well. Yeah.
So,
Yes, Professor
but I
Munir.
can tell you,
Professor Roy has been raising his hand, by the way. Sorry to interrupt for a while.
No.
So تفضل منير. I'm just
no, that's okay. Go, Loy.
I was just to show the chat doc software, but you can start to give your comment to Professor Munir because my computer is running slow.
But my comment is on this. Remember, artificial intelligence in science has what builds in it, what we called AI hallucination.
Yeah.
AI hallucination, it means it gives you data based on hypothetical data and non-real data and give it to you as a real data. So you cannot really go. So far, science is not well represented in AI because of what we call AI has hallucination, which is very, very common, by the way. We tested it multiple times. They say the literature says they give you documents. We don't find the documents. So be careful with
Yeah.
that.
I've actually tried to open the chat doc. I've actually uploaded the document and we asked so many questions. But because the computer is running slow, I would like to take the question of Professor. Yes, you can. I can hear you.
Can you hear me?
Yes, yeah.
So just to keep it brief and like everybody said, and everybody had great comments. But for the people who review the residents and fellow and research fellows, this is a registry, a VA registry, and one of the questions was, why do we have so many males and not so many females, and why is it so much white? It's because it's a VA registry. It's not the hospitals that it's not patients from the hospitals that wrote the paper. And it's the VA, it's the Army registry, so that's why it's all men. And one more comment is, why is this paper important? It's not only to tell us what patients are high risk, but in the U.S. There's a lot of reimbursement based on risk adjustment. In other words, if my hospital has more complications than your hospital, then I'll be penalized by Medicare, Medicaid, and the different payers because they think I'm a worse surgeon. So having these papers that can risk adjust the patients is very important, because then you can say, hey, I'm not that hospital that's bad, but patients are poor, they're fatter, they have more renal disease, whatever it is. So these papers are important because you can risk adjust your patients to show that you're not
thank you very much. The mic is back to you, Samer.
Excellent.
Nothing really to add. I mean, Jamal and Loai and Munir, they said all, so there's nothing really to add.
Yeah, I'm going to add one more thing. I'll never have Munir review one of my papers again. He's too picky.
Especially when
No, it's real insight into how statistics run into this statistical nightmare. 22,000 data collected from United States, and you want to grab information out just for the fear, just for the eagerness of getting publication.
I think, to be
how they
honest
play
with you,
the data, right? Yeah, I think the biggest thing is you see.
Exactly.
It's really nice to hear what you guys say, because you can see how you could play with the data to get a publication out.
Yeah, I think we had a statistician that used to say, if you
Exactly.
milk the data once enough, it will tell you what you want to hear. So you can manipulate the data in so many different ways. But again, the message for all the junior residents who are attending this journal club today, and to all others, there are good papers and there are bad papers, but there's always a message that you can get out of a paper. And you have to find something that will, there's something you can always learn and that will stimulate you to learn more, or an impetus for you to change a practice or learn more about